Let's maybe end this segment on talking about, sort of how to manage the care for these specialty populations with needs, whether it's behavioral health integration, long-term care, support services, dual eligibles, whatever the case may be. It seems as though we want to first innovate or encourage innovation because we don't have the models necessarily available widespread. But at the same time, we have to worry about regulating that as well and make sure it actually plays out. Matt, I imagine your organization thinks a lot about this.
Yeah, we do, because these are some of these populations, whether it's the Medicare, Medicaid dual eligibles, who actually represent, they're a relatively small number of people. They represent 40% of Medicaid spending, or whether it's it's the 1% of our population that accounts for 25% of our costs, the 5% of the population that accounts for 50% of the costs. That's the holy grail. If we can figure out how to improve the care and bring the cost down for that group, then we'll have figured all of this out. And that's what so much is happening right now across the states in the delivery system reforms and payment reforms. And it basically boils down to, and again, lots of different acronyms for it, but building the patient-centered care, building teams of people, trying to break down the silos. There's a physical health, there's a behavioral health, there's pharmaceutical, there's long-term care. They're all separate. You got to break them down and figure out how to get the patient what they need. And in many ways, the key way to do that, because let's face it, we live and we work and we operate in a capitalist society, you have to change the financial incentives that are inherent in the system. And for so long, the financial incentives have been to just do more, to spend more, and to just throw money where there is a lot of need, and not to intervene. And there's never been a financial incentive to get people healthy and to keep them healthy. But figuring out the data, the metrics, and the payment philosophies, and the provider engagement, that's the really hard part.
And we have these funny models out there. So we carve out mental health and substance abuse services, and then the data aren't allowed to be shared across the boundaries. So nobody could really manage without the information, right?
That's right.
So we've created these kind of managed care entities that really take care of a part of a person. And these really have to be rejoined. It has to stop.
That's right. You've got to have one.
You can sort it out, and you can share data.
Right. But you have to have one entity.
Exactly.
Is it a managed care organization? Is it an ACO? I don't know. I don't care what it is. There's got to be one entity that has all of the financial risk, upstream, downstream for a patient, and the tools and the levers to change coverage policy to affect that individual.
Got it. So maybe last question before we move on to our next segment. So with the need to innovate here, both in terms of delivery system integration and also financing, do we envision something like a CMMI for Medicaid? Will there be pilot demonstrations, experimentation, taking advantage of the fact that we have many different programs?
I think we have that kind of innovation going on. I think the challenge is catching up with it, assessing it in a hard-nosed way, and really being able to make comparisons. Part of the problem with a proliferation of innovation, if everybody's doing something different and they're all measuring it in a different way, at the end of the day, you don't really know what worked.
Right. Yeah, no, I think that's right. I think we have a CMMI for Medicaid. We have 56 states that are innovating in different ways, exactly to Peggy's point. What we need, though, is rather than continuing to let 1,000 flowers bloom in perpetuity, it's to figure out what are those pieces, delivery system, payment reforms, quality metrics, what have you, that yes, those are the ones, and build those in for everybody. Raise the boat, raise everyone's boat. Have that become a core part of the healthcare system, whether it's Medicaid or Medicare or the VA or employers. So we don't get this demo fatigue